Good afternoon, everyone. It's nice to be here. Let me just get situated with all my things. So I was thinking about how to make the transition from Jose's talk, which was excellent. And finally, he said the word communities. So let's see. All right, hold on. Okay. So the title of my talk is Catalyzing Communities to Prevent Obesity, a Systems Approach. So he talked about communities inside us. And I'm going to talk about us being inside communities. So we know it's very important to intervene at the individual level, and we also know federal policies can shape our behaviors and the environments that we live in. The area that I've spent 20 years studying is at the community level. How can we make changes with the people who live in those communities, who are familiar with their surroundings, who understand the culture, who continue to help the culture evolve, and who have relationships together? And how can we empower those individuals to take evidence-based strategies, put them in place, and change the behavior and biology of the residents who live there? So I'm going to spend the next 17 minutes taking you through the journey that I've been on for the past 20 years to catalyze to communities to prevent obesity. So no surprise to all of you, obesity is a problem. And I just wanted to illustrate that it's not just a problem in this country, it's a global problem. And you can see we're leading North America and Europe in terms of the increase in the prevalence, but it's even increasing in Africa and Asia and areas where we really never saw obesity before. So it's a global problem. We need to be concerned about it for lots of different reasons. And we need to be concerned about it in children because it has increased over the past 50 years throughout my lifetime, and it continues to increase, even though we've seen some modest plateaus. The next slide I'm going to show you is a simulation model showing that if we don't do something dramatic, we're in for a really big problem. So these are obesity rates, which you probably know are about 17–18% overall for children. If you combine that with overweight, it's 1/3 of children. But don't be deceived by that 1/3, because if you stratify by socioeconomic status as well as a number of other variables, you're going to see very different rates. So I work in disadvantaged communities across the country where the rates are between 40% and 50%. And that's where I spend a lot of my time. So this is a simulation model done by some colleagues at Harvard working on a study called the Choices Project, where they took 5 data sets that exist in the country right now, and they did some modeling to give us a sense of where we would be with children right now when they reach age 35. And it's predicted that the majority, or 57%, will be obese at age 35. So it's really an issue of prevention and treatment, and I spend my time on prevention because you probably also know if a child reaches adolescence and they're already overweight or obese, with one parent, the likelihood is 60% they'll remain that way. With 2 parents, overweight or obese, 80%. So we can't allow a child to reach the age of 13 already overweight or obese, or we're setting them up for lifelong treatment. So one of the first studies I conducted was called Shape Up Somerville, and this is Somerville, Massachusetts, which is a community right outside of Boston, very diverse. It's a gateway community, so lots of new arrivals to the US spent some time there. And at the time, I felt like we were at a point with obesity prevention science where we needed to take a portfolio of evidence-based strategies and place them into a community to see if we could transform that community and impact child weight. And my goal was to decrease undesirable weight gain in children through the period of 1st through 3rd grade. So we know children are growing. We never want to stunt their growth or stop weight gain, but we want to prevent undesirable weight gain. So what we did at the time was we took this entire portfolio of evidence-based strategies and we put them into multiple environments throughout the community. And we had 2 communities that served as controls that were socio-demographically matched. And we worked for 3 years. Year 1 was a planning and formative year where we engaged the community, and we worked hand in hand to design the interventions that would deliver the evidence. Years 2 and 3 were the intervention years, where we intervened in Somerville and measured and monitored the control children. And you can see that we worked in every community. So picture a child waking up in the morning, at home, leaving their home, going to multiple places, and then ending back up at home at the end of the day. And they may end up in 6 or 7 environments throughout the course of the day. We changed all of those environments so that there was no way they could escape the evidence-based strategies that we were implementing. And we saw some pretty exciting results. So at the time, and really to date, this is one of the only community-based interventions that demonstrated change at the individual level. So these are the BMI Z-score results. You can see 2 school years, so fall, spring, and you see the line second from the top are the intervention children with a reduction of BMI Z-score over the first year, and then an increase over the summer, and then a decrease again in the second year. So from beginning to end in the intervention community, there was a reduction in BMI Z-score, and that was significant compared to each individual control community or the combined controls, which a priori what we intended to do. So this was pretty exciting because it was really working at a community level to have an individual impact in biology. So we published these results, and in addition, we published all the other results that came with it, which were a decrease in overall obesity prevalence, not only in the children, but spillover in the adults, in the caregivers that they lived with, a decrease in sugary drink intake and screen time, and an increase in a number of other both behaviors and policies that we know are important for obesity prevention. So it really was a massive amount of change that happened in this community that resulted in behavior and biology shift. And what I'm most proud of is this has all been sustained. So someone mentioned this morning, researchers come in, they give money, they give effort, and then they retreat and things go away. We designed this from the beginning with a sustainability framework, so it would be sustained over a long period of time. And so not only has it been sustained, but it's gone on to serve as a national model. And so there are a couple of reports that have been put out in the community showing a decade of change or even a 15-year period where change occurred and was sustained. And when Mrs. Obama decided to take on physical activity, nutrition, and childhood obesity, she asked the mayor of Somerville, who was my partner in this, to come to the White House to announce it with her. So it really did serve and continues to serve as a national model. So when that study was over, I knew that it wasn't linear what had happened. It was quite complex and dynamic. So I set out to really understand what had happened in that community, and I started to work with some system scientists who would help me map and actually measure what had happened in that community. So is there a pointer? No, you can use this, I think. So think of the individual nested within all of these different microenvironments that you see in almost any community in the country, particularly suburban and urban environments, where you have the built environment, a food environment, the school environment, child care, health care, restaurants, after-school programs, lots of different environments that a child moves through. And so I think of these as microenvironments, all ultimately impacting the individual. So these lines here show you how those different environments all feed in to impact the individual. And during the course of the study, we had convened a task force, and someone talked about this morning, the Coalition Steering Committee Task Force. They exist in most communities across the country. The difference is how they actually function together and ultimately how they diffuse the information throughout the community. It turns out in this study, the task force was working very well and actually was able to influence the entire community with our help. So I really decided at that point in time, we needed to start focusing not only downstream and midstream, but also upstream. So this task force is what we think about as an upstream approach. And Matt showed this morning the compact study and those circles that represented individuals that are in leadership positions in any community serving as stakeholders who really represent the ability to work upstream and diffuse throughout an entire community. It's also important to work midstream, so you need environmental and policy changes within schools, within restaurants, within WIC and SNAP, and all the different environments and organizations within a community. And ultimately, I think the goal of many of us in the room is to have downstream impact, so at that individual level to change behavior and biology, and in this case, to change prevalence of obesity. So I became very interested in starting to segregate communities and look at them from an upstream, midstream, and downstream perspective. In addition to that, it became clear that we needed to scale the model because people were asking us after the results came out how we could bring the model to their communities. So I started to really think about and work on scale. So since that study was published, I've gone on to do a variety of things and really tried to understand and extend the science in the areas of replication, scale, and community dynamics. all of these are really important components to put together to be successful at the community level. So I'm just going to give you a sense of what we've done in these 3 areas and then bring you back at the end to what we're doing now. So we set out after the study was published to replicate it, and we worked in 18 communities across the country, bringing the Shape Up Somerville model through RCTs and demonstration projects, and reached about 200,000 children. And that was terrific, but that's about 0.25% of children in America. So at that time for me, it felt not as satisfying as I wanted. I wanted to scale bigger, and I wanted to actually do more. So a lot of success and a lot of learning came out of this, which really refined my movement forward. I also took on a large study called Child Obesity 180, which was funded in large part by the Robert Wood Johnson Foundation. And here we took not only the rigor of science, but the innovation of business, and really tried to rapidly scale up a lot of evidence-based strategies to bring to children across the country. In science, we tend to work slow, and there's good reason for that. But once we know something works, we need to work fast. And we're not very good at that. So I started to work with some CEOs from around the country, from healthcare and business and not-for-profit organizations, to push me to work faster and to actually scale up these evidence-based strategies and reach millions of children within a 10-year period. So I'm going to give you an example of just one of these initiatives and how we did that. So we decided to work in the restaurant space on children's meals, in schools to increase the quality of physical activity that a child receives per day, all heading toward that 30-minute requirement. In out-of-school time organizations like Girl Scouts, Boy Scouts, youth sports, 4-H, to incorporate evidence-based practices that would make their meetings and games, et cetera, healthier. And last but not least, on the school breakfast program in America, to not only increase the quality, but the delivery system, particularly enhancing breakfast in the classroom. So these are all areas that collectively formed another portfolio that I knew had evidence toward healthy weight for children. And we went about scaling them one by one across the country. So the way that we did it with the physical activity program is we started with a crowdsourcing technique. And that advice came from the private sector. Find out what's going on. Don't create a program that you think communities want. Ask communities what they're already doing. So with the help of the First Lady, we ran a crowdsourcing competition. And she announced it via a viral video and said, if you're a school doing a physical activity program, tell us what you're doing. Submit it to this competition. We'll pick some winners. We'll refine them and make sure that they are delivering the right dose. And then we'll scale them up. So we got 500 applications from around the country. No surprise, people are hungry to get involved and to make a difference and to do better. And we chose 3 winners, and of those 3 winners, there was a before-school physical activity program, a walking running program, and a classroom-based activity break program. We ran a pilot with 1,000 schools across the country to really see which one we wanted to put all our effort into to really scale big. And as a result of that 1,000-school pilot, we decided on the walking running program for a whole variety of reasons that we've published separately, and we decided to scale that up in a big way. So we developed something called the billion-mile race, which is incredibly ambitious to get 1 billion miles logged by children across America. And we had a short-term goal to do it ourselves and to get to about 10,000 schools and to reach what we hoped would be about 10% of the goal, and then we intended to hand it off. And that's exactly what we did. So we got to 89,000 and then 9,000 schools. So we got to close to our goal. And we handed it off to the New York Roadrunners Association. So now they're taking it to 1 billion miles. Through the course of this, we ran a randomized control trial. We collected an enormous amount of data looking at the quality and quantity of physical activity that kids were receiving. And hopefully this will grow now into a much larger program. So 10% of schools, about 10,000 schools, is a lot of schools across the country in all 50 states, as you can see in this map. But we really want the New York Roadrunners to get to 25,000 schools. There are lots of New Jersey schools that were actually part of this. I'm going to skip my next 2 slides, which talked about our restaurant initiative. We've published a lot from that. But let me just say in short, we worked on the supply side. So it's important to increase demand, but everyone has told me through the years, unless you have a good supply, it's very hard for families to make a good choice. So we worked on the supply side to really change what's available for children's meals in restaurants. And I hope that you've seen some change over the past couple of years. A long way to go, but I did work behind closed doors with some of the largest brands in the country based on some research that we conducted to help them make some of those changes. We also have to work on demand, there's no question, but the supply had to change. You can't have one healthy meal hidden in the corner of a menu and expect anyone to choose that. It needs to be greater than 50% of the menu. That's the tipping point for someone to change their behavior. So through the result of CO180, which has concluded its phase 1 efforts, we published quite a bit. We had a lot of partners across the country, and we reached about 12 million children with these initiatives. They're all available free to anyone who continues to want them, and I'm happy to talk with any of you to get those into your hands. And we did reach children in all states, but we had an intentional focus on states with those children who are at greatest risk for obesity. So community dynamics is where I want to spend the rest of my time here. And I want to talk about what I think is really important to make all of this work, and that is human relationships and human dynamics. So the things you're going to take away from today: epigenetics, the microbiome, and community dynamics. We can hand any community a set of evidence-based strategies and think that we're doing a good job, but unless you work on the how, nothing's going to happen. I've worked all over the country, and I know with really great effort, people can't operate and move forward unless they understand how to function together as a group. And we can't expect, just because we call 20 people around a table, that they're going to figure out how to work together well. So I'm working on the science now of how to facilitate the evolution of community dynamics so that it moves in a positive way in a community and enables individuals to disseminate those evidence-based strategies. So COMPACT was already mentioned, which is a study that was funded by the NIH to understand and leverage existing systems within a community to implement an upstream approach to obesity prevention. And Matt mentioned our working hypothesis, which is stakeholder-driven community diffusion. So picture any community in America with a group of stakeholders, roughly 20 people representing organizations and institutions in that community working together. How do we help them do better and diffuse the strategies, not to another 10 or 20 people, but to hundreds of people throughout that community? So this is an example of social networks. And from the original Shape Up Somerville study, we went back and looked at that social network. So we had that stakeholder group, and they were diffusing to people throughout the community. So the egos are in blue, which are the stakeholder members, and the alters are in red, which are the people they began to diffuse to. This is what was naturally happening during the study, and we went back and looked at the discussion networks, the influence, the closeness, and learned a lot about how that particular stakeholder group worked together so we could move forward with new stakeholder groups. This is the social network of a study that I just finished in the community of Somerville working on early childhood obesity prevention. From a group of 16 people on the stakeholder committee, we actually interacted with 530 people. And that's really what you want. You can't depend on a small group of people to change the entire landscape, but you can depend on them to diffuse to the right people to get the information into their hands to make the change. So behind this is a lot of computational modeling that we're doing to really understand the dynamics and arm communities moving forward so they can do the same. And communities can also map and model. So this is a dynamic causal loop diagram created by community members working together to externalize their mental models of what's happening in their own community and create a roadmap and a visual that they can all buy into together and set strategies to move forward. This is often not done. People come to the table with mental models, and the loud people speak up and the quiet people don't say anything. But if you get people to work together through an approach called group model building, you can get people to co-construct something that represents their own community and what the needs are and what the appropriate strategies are. So I want to leave you with a new article that just came out from a group called FSG. And it's a really interesting read if you're thinking about working at the community level. And it says that systems change is about shifting the conditions that are holding the problem in place. And I know many of you tend to work at this top level, where you're trying to change policies and practices and resource flows at the community level. But I would argue if you don't address the semi-explicit and the explicit layers below it, it's very hard to make any change in that top level. So a lot of the work we're doing now targets the relationships, the connections, the power dynamics, and the mental models. And I'd be happy to share more of this with any of you offline. But if you're working at the community level, it's not enough to have the what or the evidence-based strategies. It's really important to understand the how to put them in place and make lasting change. Thank you.